Uh, Thank you very much for joining us today for our LabCoP Extended ECHO session. My name is Francis Ochen from the African Society for Laboratory Medicine, and I'm delighted to be your moderator today. We have an exciting session that will run for 1 hour today. We'll take 2 presentations and get to the questions and answers. Kindly join the discussions through the chat. We do have language interpretation services, so please keep to either French, English, or Portuguese. Do not stay on the off channel, depending on your preferred language of choice. Our session theme today is advancing patients' care in Africa through integrating and multi-disease testing. We do know that Africa faces a high burden of infectious diseases, and this burden inevitably strains the healthcare system and, of course, compromises access to early and timely diagnosis and treatment monitoring. We are also aware that significant investments in establishing modern laboratories have been made and test platforms placed all over the continent to support specific disease programs. And this forms a great foundation, really, for the introduction of other infectious disease screening programs. On the side of our industry partners, global competition and increased regulation really dictates that manufacturers should optimize and integrate their laboratory testing and measurement device management processes. We also know that these testing and measurement devices with broad assay menus designed to run multiple tests does improve laboratory efficiency and access to diagnostics without significant additional investments into our healthcare system. And so in today's session, delivered by Roche and the Ministry of Health of Mozambique, we look at potential advantages of integrating diagnostics and multi-disease testing for programs, networks, and laboratories in Africa. We will also look at some of the challenges and opportunities of diagnostic integration across infectious diseases and programs and how this can be addressed. And then we will focus on the example from Mozambique that demonstrate how we can really leverage on existing laboratory capacity to increase access to diagnostics through multi-disease testing using molecular platforms. And to take us through today's session, we have 2 presenters. Our first presenter will be Mr. Edwin Muirui, and Edwin is a product manager for tuberculosis and hepatitis at Roche Diagnostics. After Edwin, we will then have Dr. Felix Pinto, and Felix is currently serving as the head of department, diagnostic support services that encompasses clinical pathology, pathological anatomy, forensic medicine, imaging, and radiotherapy at the Ministry of Health in Mozambique. Let me now hand it over to our presenters to take us through the session, then we'll get back at the end with questions and answers. And kindly keep your questions and comments coming through our chat. Thank you very much, and let me hand it over to Adrian.
Great. So I'll not introduce myself. I have been introduced. I'll talk about delivering integrated diagnostic testing, and this is through a partnership approach. So we'll go through several topics. We'll look at guidelines and recommendations, benefits and barriers, country examples that are real-life testimonials, and then we'll also look at how Roche partners to support integration. So maybe to start with is to ask ourselves what integration is. I would define it with an analogy. So let us assume we have a family of 5 people who need to travel on a safari from point 1 to point B. And these people decide to go, each person with their own car. So they are traveling 5 people to one destination from one family, each with one car. So those are 5 cars. Integration would mean putting all these people in one car that can carry 5 people. and this increases efficiency. So for me, I would define integration in something like that, where we bring in things together that are related so that we can increase efficiency and reduce costs. So as the moderator said, Africa is struggling and working hard to achieve elimination of the various infectious diseases across here in Africa. And we are faced with challenges where we have limited resources that we are expected to work with. And this could be in terms of finances or even human resources. And therefore, programs, donors, and implementing partners are prioritizing diagnostics to help strengthen and optimize health systems as we look towards achieving the elimination goals. And opportunities to integrate exist. And this can be done through 3 different levels: at the program level, at the network level, and within the laboratory level for the various infectious diseases that we are talking about. And as Roche, being a partner, we have the capabilities, we have the technologies and the tools that can help integration across these diseases, and we will look at them as we move on. So WHO does recommend integration across these disease areas. If you look at the Molecular Diagnostic Integration Global Meeting of 2019 between WHO and ASLM, they encourage countries to use existing technologies to integrate for the various disease areas. And they also encourage integration at the program level, for example, in financing to reduce costs, in supply chain and procurement to increase efficiency, training and HR for human capacity development, sample collection and transport to avoid duplication of roles and even reduce the cost of tests, and also in terms of data management and quality assurance to ensure we are all operating at the same level. So what are some of the benefits of integration? And just to say, PEPFAR also supports integration. If you look at the document highlighted there, they really support integration as a way of achieving our elimination target. So integration provides diagnosis in a one-stop shop. If we look at another analogy, let's say you're going home today and you want to buy milk, bread, and sugar for your family, but then you have 3 different shops, each sells one thing. So rather than going into one shop to get everything, you have to go to 3 different shops to buy one milk. The other one can only sell you bread, and the other one can only sell you sugar. But if we integrate, we are able to provide a one-stop shop where a patient who has who needs services for HIV, for TB, or for HCV and HPV, they can get them all within one stop at one place. So there is no need of a patient being a TB patient in this lab, and when he goes 30 kilometers to this side, he's a HIV patient. The other thing, it also enables us to respond to the global co-infection crisis. As you are all aware, co-infection of HIV, TB, HIV, HPV, and enables us to respond to pandemics and outbreaks. This was very clear during the recently concluded, or as we think it was, COVID outbreak. It also improves on test efficiency and turnaround time. We are working with very small turnaround times. If we're able to integrate, we can achieve this. And finally, lowering costs by leveraging the existing platforms rather than new ones, and not only platforms, but also existing infrastructure, such as laboratories, such as sample transport networks, and also manpower. So we can collaborate at the different levels to achieve integration. So for example, at the program level, collaboration with the Ministry of Health, the different TWGs and implementing partners, so that we have a common goal. At the clinic level, do the healthcare providers know that within this one lab, you can be able to get your TB test, your HIV test, your HPV test, your HCV test within 24 hours. In terms of sample collection, how do we integrate movement of samples from the patient to the lab and all the way back? In terms of laboratory management, how do we look at the workflows? How do we design our labs? How do we train the people at the lab in order to increase efficiencies at the lab? In terms of result delivery systems, are our systems able to integrate into the existing laboratory information systems, or for every other new disease area, you need to come up with a new LIS system, or for any other instrument. And at the end of the day, how do we link all this to patient care? This could be through apps or whichever ways we may find to integrate. So Roche would like to integrate with our partners across these different areas of the continuum. And these cut across the program, the network, and the laboratory level, as we mentioned earlier. We have some experience across the spectrum. In terms of the program level, we accelerated response to COVID-19 in several countries, as you can see there. And this, we worked with the laboratory directory to identify systems which have capacity. So most of the instruments that are within these countries are being used for HIV testing, and they are underutilized. You'll find that most of them are operating at a capacity of about 50 to 60%. So we identified this, and we were able to utilize the same ones for COVID-19 testing. And we also leveraged on the HIV sample transport system to transport the samples for COVID-19. At the network level, this is ongoing work where we are engaging across several countries to try and utilize the existing networks for sample referrals in order to introduce TB diagnostics in the urban and the peri-urban areas. As you know, in 2021, WHO recommended high to medium throughput instruments for TB testing. And rather than coming up with new sample transport networks, we are trying to work with these countries to see how we can leverage on the existing sample transport networks so that we can introduce TB testing in the medium and high throughput sectors. At the laboratory level, here we assess the workflow for the cobas instruments that are within the existing labs. These are mainly the HIV testing labs. We have done so for hepatitis and HIV in 4 countries, and we have done the same for 6 countries. Those are in progress for HPV and HIV. So we collaborate with the existing lab and the ministries to see how we can maximize the existing instrument so that we can use the spare capacity that they have. We acknowledge that there are some barriers to integration, and these barriers, we've classified them into 4. So the main one at the higher level is the allocation of budgets and resources, where we all know programs operate in silos. And here, as Roche, we have capabilities to help address this, where we can facilitate workshops and roadmap development to help programs to work together rather than in silos. And from our experience, we have a few projects within which we can share data and evidence. In terms of sample referral networks, again, these remain fragmented and inefficient. And as Roche, at the network level, we are able to help programs and laboratories to pilot integrated sample transport networks in order, and we do this by doing visioning workshops, where we sit with you and identify the ideal future state, and then we work backwards to see how we can be able to achieve this. At the sample preparation level, this involves changes in the laboratory processes. So at the lab level, we are able to conduct trainings on laboratory systems and personnel as well. We assist with development and forecast. This helps to inform workflow. If we have a forecast of what you have, we are able, or what your needs are for the different disease areas, we are able to come up with a good workflow for you, and I will show that as we go on with the presentation. We also help to co-create lab designs to optimize the workflow and output. In terms of result delivery and data management, at Roche, we have the capabilities to design solutions integrated that are designed to integrate into the existing LIS. So there is hardly need to come up with a new one. Since we have the capabilities to help integrate into this. So I'll go into some country examples and real-life testimonials. The first one is Nigeria, where we have done integration of HIV and SARS-CoV-2 at the National Institute of Medical Research in Lagos. They call it NIMA. So here we were able to help them achieve an annual throughput of HIV of 151,000 tests and COVID testing of 36,500 tests annually without interfering with the existing HIV patients. And here we considered things like sample transport and testing allocation. We did a lot of scenario planning with the lab managers, and we did training in terms of sample preparation, resource mobilization, and also storage. Again, if we look at the same country, Nigeria, we are working with HIV and HPV. This is currently ongoing where we have HIV about, they are targeting 228,000 tests per year and HPV 3,400. Again, with the same kind of approach, we have been able to help them achieve this. And I would like to focus on something here that we're calling hypercare. Hypercare is where once we have done training with you and we have started to work on integration, we have our experts who stay with you at the site for a predestined time or the time that the lab feels is suitable. So it could be 2 weeks, it could be a month, where they handhold you until you're able to operate smoothly without any hitches here and there. Maybe to show it at a larger scale, even though this is not in Africa, we can achieve even much more across very many disease areas. And this has been done in Germany, where we have a fully automated lab from the time the sample comes in up to the time the sample goes out. And they are able to come up with a workflow design that allows them to do all these tests on the same instrument. So rather than having different labs, all these are done within one lab. And this can be done even here in Africa. We have labs and that have the capability to handle this kind of work. So let's look at an example of a situation where a laboratory is planning to do a workload of 100,000 tests per year for HIV, TB, HPV, and HCV. So, and this is being done on the COBA 6800 system. So we have experts who will come on the ground with you, depending on your output. They will be able to narrow it down to the number of samples per day, and then figure out the days that you're operating per week, the controls that are required, the equivalent turnaround times that are required. And this also puts into consideration the turnaround time that you're targeting. So in this example, we are targeting a turnaround time of 24 hours. So with this, we're able to find the suggested run frequency. So for this case, we would be able to do 3 runs of HIV per day, 2 runs of TB per day, 1 run for HPV, and 1 run for HCV. And the total instrument time running would be 11 hours, and the final operator intervention would be at 4 p.m. And this leaves an additional capacity that can be utilized for other things. So it depends whether your lab is running 8 hours, 12 hours shifts. So in the next slide, I am going to show you what the workflow would look like. So this is the same lab, the same scenario, COBA 6800. We're targeting 100,000 tests per annum, and we're looking at an 8-hour or a 12-hour shift. So in the morning at 8 a.m., you would do your weekly maintenance if it is required for the instrument. And then at around 8:30 p.m., you load your HIV samples for the run, for the first run. So remember, our instruments allows you to do continuous loading. You do not have to wait until the first run is over so that you load the second run. No, as soon as the instrument is ready, it will alert you and you can start your second run while the first one is still running. So at around 10, the operator will start the second HIV run. So they will load another 94 samples for HIV viral load. And at around 12, they can load another run for HIV viral load. So at this time, we are running 3 runs at the same time, and we are almost already getting the results for the first run. But remember, during this period, the person has, the hands are not engaged. So we call it hands-free time. Here, they can be doing the pre-analytics. For example, for TB, for our test, you have a pre-analytical step where you need to inactivate the sample, you need to sonicate, and you need to incubate. So that just before 1, you can load now the MTB samples. The MTB samples will be loaded by themselves, another 94 batch. So by the time you're finishing your 8-hour shift at 4 p.m., you will have done over 470 tests. This means that 470 tests, 470 patients for HIV and for TB will have gotten their results within the same day. They can get their results within the same day or by latest the following day. However, if you're running a 12-hour shift, then at around 3, you can run a combined plate for HPV and HCV because they have the same PCR profile. So you can mix them within one plate, and the system will be able to know for which well I am doing HPV, for which well I am doing HCV. And at around 4, you can run your final MTB batch so that in a 12-hour shift, you're able to give almost 700 results for your patients. So think about this scenario. What if this was being operated in different labs? Or if it was not integrated, we would have 3 instruments, one doing HIV on its own, another one doing TB on its own, another one doing maybe HPV or HCV on its own. So here we have saved 2 instruments, we have saved a lot of time, and we are maximizing the instruments that we have. And as you can see in the orange areas, all this is spare capacity. So if your lab runs 24 hours, you're able even to double the output within a single day. So think about that in terms of cost efficiencies and in terms of patients who are able to get their results within the same day if we focus on integration. So in summary, we can do this through co-creation, where we work together as a team in a holistic manner. We can leverage on the experience from Roche. We can optimize the existing systems and platforms, and we can come up with unique solutions for everyone. But at the end of the day, this requires a lot of partnership. And as Roche, we come as a partner. In the next few minutes, I'll also take you through our capabilities. And the first one is what we call the healthcare consultants. So these are certified consultants within Roche. We have 300 of them. And in Africa, we also have. In Q1 of this year, we had a workshop with the Nigerian ministry where we were trying to look at integration of HIV, TB, HPV, and these are highly certified consultants and change management experts. They have experience that is cross-functional, so be it at the lab, be it at pathology, engineering, administration, pharmacy, biomedicine, or medicine. So these are available to come and work with you. And if you give them your scenarios, your lab sizes, your throughputs, or what you're targeting, like the examples we went through, they're able to come up with a workflow design for you. They're able to train the lab personnel for you. And they're able to handhold you, as I talked earlier, through the hypercare process. They're able to handhold you until you're able to run on your own. And for this, it is customized for each project. If it is operational effectiveness that is required, they provide technical consultancy for lab designs and simulations. They can also do scans for systems and sub-processes. And also, if you need improvement, they are able to use the existing resources to show you how you can sustainably improve on your outputs or on your operations. At the organizational sustainability, they are able to work with you for your vision and strategy development. They are also able to work with you for value stream analysis to enhance collaboration and integration. And for healthcare transformation, here is where it's really important. This is training on change management. We can all acknowledge that change sometimes is difficult, but they train you and handhold the team until we are able to achieve this. So at the molecular lab at Roche, we have solutions that fall under what we call the molecular work area. And these instruments are the ones that are able to offer you integration for your molecular tests. The molecular work area is defined by 4 aspects. The first one is absolute automation, where we are able to to ensure that our processes are automated. And this automation ensures efficiency, reduces the interaction of the human interaction with the sample, therefore, with the sample and also with the instrument itself, therefore removing issues to do with human errors. So in addition to absolute automation, we offer consolidation, and consolidation is where the routine tests are performed on one platform. As you can see, we are able to do donor screening to infectious diseases, to sexual health, through respiratory diseases, to antimicrobial stewardship, all these through the same family of instruments, and that is the Cobas 58, 68, and 8800 systems. So this consolidation removes the need for new instruments and increases operational efficiency. We also offer integration, where we are able to connect seamlessly to the existing laboratory IT solutions. So at the end, you can see Cobas IT solutions and data analytics, and this can also be done at the pre-analytical level. So this enables reduces the need for so many changes, where for this country we're doing that, for this country we're doing that, but for our systems we're able to allow you to continue doing with what your LIS does, and we adjust ours to fit into yours. Within the molecular work area, we also offer unrivaled standardization. This is where we have a common user experience within the same family of instruments. So whether you're using the smaller instrument, the medium size, or the bigger one, you have the same user experience. This reduces the need for training and retraining. And this also allows for scalability and configurations. So if you want a standalone instrument, it is able to do that and do integrated testing. If you want full automation from pre-analytics to post-analytics, then this kind of standardization allows a small lab and a big lab to enjoy the same privileges. So at Roche, we pride ourselves in that, and we would like to partner with you in terms of integrating for these disease areas that we have targets to achieve. And we want to work with you in a partnership manner where we can utilize the capacity that we have inside in terms of technical capabilities, as well as the existing instruments, so that we can be able to bring in integration into Africa. And at this point, I'll stop my presentation and hand you back to the moderator. Thank you.
Thank you very much, Edwin, for that very exciting presentation. Our colleagues, keep your questions coming through the chat so that you can get additional insights into what Edwin has shared with us. At this point, let me bring in a second presenter, and then we'll do the questions and answers at the end. At this point, I'm calling upon Dr. Pinto to please take us through your presentation. Thank you.
Thank you, Francis. Can you hear me?
Yes, we can hear you.
Thank you. Good afternoon to everyone. And I want to thank ASLM and the colleagues to invite me to talk about our country. And we're going to share experience and opinions about molecular platform integration in our health system. And based on that assumption, this is the summary and overview of my presentation. Mozambique is a country with approximately 34 million inhabitants, and the projections said that in 2044, we're going to be 50 million, because we are growing 1 million inhabitants per year, and almost half of our population are under 15 years of age. And currently, we are seeing in our labs more than 5 million of patients and more than 11 million of exams going through our lab system, and we have around 2,500 professional. Our health sector do not differ of most of countries around the region, and we recently approved a new health policy that divide our health system in three major areas. Public sector that comprises the more than 90%, and we have private that goes from 3 to 5%. And now we create a community subsystem to fill the gap between health sector and the community, because we do have around 65% coverage of our health facilities and health centers, and there are some that still missing. And we are divided in central provision and district level of management in our chain. And we do have around 1,900 health facilities, and from these, almost 70 are hospitals, and from primary, secondary, tertiary, and specialized care that we call quaternary. And we have here in the bottom some examples from your left to the right. We have Maputo Central Hospital. We have another general and provincial hospital, the two image in the middle, and district hospital on your right. And to talk about lab testing and what we really do need to go and screen in our health services, we can pick or mortality or the main cause of diseases that we have. And I choose mortality because recently we did a community survey, and based on community level data, we saw that the 10 major causes of death, the first one is HIV, the second is cancer, that came up in our community-based data study. And if you just look the fourth and the fifth, we have cardiovascular diseases and also gastrointestinal infections, diarrhea, and those seasonal diseases that are caused through waterborne spread disease, and we have pneumonia and so on and so forth. And based on this, we have in our country around 500 labs that only cover a quarter of the amount of health facilities. And these labs has around 2,000 instruments. From there, we can identify around 400 POCs for molecular diagnosis and 40 conventional instruments for viral load mainly. And currently we are doing a lab map in an ongoing process to evaluate the data that we generate on the study. And we spoke about our health facility network and which kind of labs we have from hospitals. We have 4 central hospitals, 7 provincial hospitals, 9 general hospitals, and 50 district hospitals. And from all these network, we can manage to get a sample referral system that is a complement for what we have on outpatient demand, and also inward demand inside of hospital. But aside of these, we have this network that connect those health facilities and health centers that doesn't have a laboratory through the hubs in our system were in a year from January to December last year, we covered more than 2 million kilometers. We collect around a million samples, and we have different schedules to collect every type of clinical samples. Different than other countries, we didn't went to only one type of sample like HIV for viral load or EID or TB. Our sample referral system cover entire clinical samples from HIV, TB. We have hematology, biochemistry, microbiology, public health concern samples. We do have also anatomy pathology where it goes through cytology and biopsies as well to try to cover the gap that we have into our system to refer patients to the hospitals. Rather than transfer patients, we prefer to transfer samples. And our lab network, we do have 14 molecular labs, and we have 3 new labs planned to be opened. And from POC, we have MPMAs and we have gene experts, and also we have conventional platforms from Roche, Abbott, and Ologic. All of them are 40 in our system. And which are the opportunities that we are seeing than the classic HIV and TB? We are seeing bacteriology, we are seeing AMR. Now we have this global health security agenda where we have to put in our strategic plans the capacity and the skills to go and identify pathogens that has potential or high risk for a pandemic and all other major public health diseases. We are looking for immunology and as well other molecular biology regarding on oncology, because most of infectious diseases are linked to cancer as well, like HPV and other parasitic infections. We are also looking at hemoglobinopathies and hemophilias and other infectious diseases transmitted mainly to sexual related. And one of our priorities is platform integration, where we are seeing from HIV, TB, hepatitis, and HPV mainly, and as well for cancer that we now are implementing only at Maputo Central Hospital. And when we study most of these companies that provides us platforms through PEPFAR initiative for HIV, we end up seeing that a part of HIV, we have opportunities to integrate, for instance, HBV and HCV, that is a major cause for failure and treatment in HIV patients, and also the major driver for cancer diseases like lymphomas and also other leukemias. And now for blood donation, not only HBV and HCV, we have to look after HEV because the livestock can carry this kind of virus. And Zika, we had around 2012 epidemic of Zika and chikungunya in some continents. And as well, we are dealing with preventive infections like HPV that can interrupt the course of the numbers of cervical cancer that most of our countries are seeing. I have an example from Brazil that they are implementing for around 20 years HPV vaccination and treatment. Nowadays, they are not seeing the cervical cancer, the same number that they used to see back in early 2000s. And for the transplantation, there are countries that started transplant. We have BKV virus as determinant virus for those patients that has kidney transplant and then start having failure and also rejection of the kidney transplant. It's some examples that we have, and we currently have opportunities on tuberculosis and some cancers like breast cancer and ovarian cancer and so on. And our experience on integration says that it's important to leverage this idea at three main levels. One is strategic, and the second one is operational and technical. I think, Edwin, that show us a great examples how to go through this integration process. In a strategic, we must have clear guidelines in our country where the instruments, where the lab is not a dedicated lab, is a lab that must serve all diseases according the profile of main causes of mortality or main causes of patients that are hospitalized, where through this process, we have to establish the guideline for testing. We as a country approve menu of tests per level of attention from a specialized level till the district level or community level to maximize this effort. And in an operational process, it's important to have the picture of the network. We talk about lab network, through lab map, through data reports, and also sample referral systems to cover the gap, and LISs to manage the entire network, and technical groups that discusses all the needs in each health system, and also demand the lab processes studies to get the really understanding about the level of utilization of the labs, and as well how to integrate and which labs is possible to integrate, which labs we can integrate fully or partially or not allow them to integrate. And based on that, we have to establish requisites to incorporate this kind of innovation. We did this when we introduced HPV in our labs, and we did the different when was a COVID because of the pandemic, and was urgent to put available the tests in our network. And it's important to develop a checklist to guide the process of integration. Sometimes we do have one order that say, okay, yeah, you just do the integration, but the technical group, the policy makers and the top managers that decide to integrate, we do have, we must apply a checklist to guide the entire process, to not interfere to the current processes that are in the labs, and to also to engage the lab team into the process, not to only deliver a mandatory task to them, and define which tests goes to which lab, and how to monitor from the start point of the implementation till the end of process of implementation. It's one of big challenges that we have to went through. And the practical example that we have, it's the initiative from WHO to reduce the number of patients that we are seeing with cervical cancer, mainly female patients. Doesn't mean that the male patients are not going to develop cancer through HPV infections. We saw a couple of these patients with cancer, but mainly to female patients, where the target is vaccinate around 90% of female population and screen around 70% of them, and those with positive screen test, treat them through ablation, or we call VIA. No? And based on these assumptions, through the PEPFAR and CDC funds, we, as a country, develop a project called Salvo, that the main objective of this project is integrate the whole journey of the patient and see which are the opportunities to block the infections pathway and prevent or eliminate cervical cancer in the end of the day, applying HPV DNA testing. And we introduce these in our labs, where we have Cobas 6800. We have these platforms in 2 major hospitals, one in Maputo and another one in Nampula. And through the sample referral system to also test the flow, where I'm going to share afterward, where we did a lab scan, one of the approaches that Edwin mentioned, that assess the operational process, where we have 4 different samples to 2 major diseases, namely HIV and HPV, where HIV, we are looking for a viral load to through plasma and the plasma separation card, and EID to DBSs. And HPV, we have liquid sample to implement in our labs. And based on these assumptions, we ask for a lab scan that is an approach that apply Lean Six Sigma based tools to assess the entire process in our labs in a pre-analytic phase, analytic phase, and post-analytic phase, where the team went to the lab and assessed all the procedures from the sample collection and sample arrival at the lab, how the sample are taking care in our reception area, how we prepare those samples, and how the lab drive all the processes to integrate the samples into the platforms. And based on the last table that Edwin showed, we assess the processing phase in the lab, how we validate the results, and how we send back the results to the clinics and the physicians. We saw a room of opportunities in each phase, from a reception to avoid duplication, what was one of the things that we saw. And rather than duplication, introduce the data directly to our LISs, and also prepare the samples in a good manner to fill it in our platforms, and turn the process of verification and sample preparation and processing within the lab more efficient, and the validation process as well more efficient. We end up seeing that even adding a new analyte in our lab, with this introduction did not have impact in a turnaround time in the end of the day, even in within the process during the work journey. The impact was minimal in our labs, and we still delivering a good results in a shorter turnaround time, because the process of lab scanning also improve the performance of our labs in all our teams as well. This is one of examples that we have regarding integration, and we have additional examples on our gene exports machine, where we are doing at Maputo Central Hospital MLC, that is a chronic myeloid, CML, chronic myeloid leukemia, where in the same platform it's capable to do TB, COVID, and CML, chronic myeloid leukemia, to deliver different results to hematology, to infectious disease unit, and those that are screened in our emergency ward. We are doing integration at Maputo Central Hospital. And this is our experience. Now we are planning to expand for HBV and HCV, and also scale up our experience that we have currently at Maputo Central, Maputo Province, to the north of the Mozambique, to see how is the same project in a different environment, how we can deliver the results. And I have to thank my colleagues of the department, the partners of implementation, our vendor that embrace this initiative and our project, and the donors, and our technical and scientific experts that supports us to do a lab scan at Mavalane General Hospital and Nampula Central Hospital. I say thank you.
Thank you.
I send back to Mer Francis.
Very much,
Thank you,
Pinto, and a very, very elaborate presentation from Mozambique, and very well done by Dr. Pinto. And I'm not going to try to summarize this because we're really pressed on time, but I really want to appreciate the fact that even your integration work that you're doing, be it platform integration, you have guidelines that are really supporting you to do the integration on either currently existing platforms or those that are yet to be acquired. And that is really a great thing to have as a country. But also you have a basis for your integration and some of the guiding principles, including really the existing guidelines out there that should be followed by countries. We have quite a huge amount of questions that have come through the chat. I am also glad that we've had most of them addressed by colleagues from Roche, and I think the Mozambique team. But just to highlight a few, and we'll be very brief, I'll send the first two Edwin. And Edwin, you have available opportunities really to support integration at country level. Just two quick questions. The first is, what is the cost implication to have the team of the consulting team support a country walk through their integration path? And what does it take to actually reach to that consulting team from Roche?
Thank you for the question. So the cost implication to have the consulting team come to your country is absolutely zero. You only need to contact Roche. You can contact myself or any generic email from Roche or your country representative, and we will have them come into your country at no cost at all.
Great.
Yes.
That's exciting to know. And colleagues, that's some information that you really need to have. And just again, on integration, we do know that there are multiple platforms out there. And I know there has been a question to this effect, and some answers have been provided. But just to expand on that, the issue of existing platforms, I know that probably at the time when we were placing some of these platforms, the idea was not to integrate testing on them. But now we have the opportunity to integrate testing. Is there some cost that might be related to upgrading the softwares of the current existing platforms so that they can accommodate the increasing latitude in the test scope that can be run on such platforms?
Thank you for the question again. If you want to upgrade an existing instrument, let's say it was only doing HIV, to integrate other tests, again, for this one, there is no cost at all. This is just a system upgrade for the software, and it will be able to run smoothly at no extra cost to the laboratory.
Okay, great. So thank you very much, Adrian and team. Let me just get to Pinto with one quick one as we get to the last moments of the session. And Pinto, you've done a great job. And I know that some of this may have been dealt with during the presentation, but just kindly clarify to us, you do have guidelines at the national level. And I do understand that most guidelines are really high-level documents. But when it gets to the facility-level operations and supporting the implementation of integration, do you have additional SOPs that individual facilities have to follow to guide their which prioritization they should take? If they have 2-3 samples, which ones do they start with and which ones do they end with, given the context of your country?
Thank you, Francis. Great question. As was the first experience, we did not have a guideline at the time. We rely on the process evaluation to inform us which steps we have to take in the second phase, or if we want to scale up for the next labs. And through the assessment that we will benefit, we end up learning and also seeing how to do the integration and which are the key points for guideline, because we have to understand that process assessment is we have a main drivers, but in the end of the day, each lab has its own characteristics, and we have to rely on a lab environment and also personal skills to improve it. One recommendation that I can leave here, and the lessons learned, it's a key to involve the entire level of management from the central level. When this initiative started, we sat with our top managers and we explained them the public concern regarding on HPV, which are the benefits that we can gain, integrate them. In terms of procurement, we don't have to go in a new tender. We don't have to procure new new vendor and which steps we can anticipate, and also through the technical team we set together with cancer program manager and also clinical lab team to develop the entire communication and how we're going to deliver the instructions to the labs, and the team went to the lab themselves to follow up all the process with the lab staff there. I think engage all stakeholders of the process is key to avoid misunderstanding, miscommunication, and to turn in an efficient process to the entire network that you have in country.
Thank you. Thank you very much, Pinto. And I will take that also as your closing remarks for this very exciting session. I'll now hand it over to Edwin. And Edwin, as you do, you will do my last question, but also use that opportunity to give your closing remarks. But just as a general disclaimer, I need to note that hosting any one of our collaborating industry partners does not constitute endorsement. And so we're just here to share facts that are available from the industry partners. Now, Edwin, as I hand it over to you, kindly comment as you do your closing remarks, and colleagues, our apologies for overshooting slightly, but it has been an exciting session. Kindly comment on the fact that we have so many countries with so many testing hubs out there. And there is a worry from Justin that over-integrating might actually render some of the testing platforms and testing hubs redundant. What is your comment on that as you close?
Thank you. My view on that is if we have too many testing hubs, then already the instruments that are existing there are underutilized. Then my idea would be to maybe relook at the network organization and place instruments where they can be of much value. If it is a point of care instrument, take it where it can work efficiently. If it is a medium-sized instrument, then you can use those ones, especially to avoid wastages of consumables. For my closing remarks, I would like to thank everyone for attending and for your questions. And I would like to ask us to go back to our programs, to our networks, and to our labs and start rethinking about integration, because this is the only way we are going to achieve elimination based on the limited resources that we have. With that, I thank you, everyone, and I wish you all a good evening.
Thank you. Thank you very much, Edwin and team from Roche. My particular appreciation goes to Mehan, who was very helpful in organizing this session. Our colleagues, because of time, and again, my apologies for overshooting, but we will allow the platform to run for the next 10 minutes. Most of the questions have been answered in the chat. So if you're looking up for your answers and we've not been able to include them in the few that I've picked out, kindly run through the chat and definitely you will get the answers placed there. The Roche team plus also the team from Mozambique will also still be available to check if there are some questions that have not been answered, and they will be addressing them in the chat. We'll leave the platform open for the next 10 minutes. Thank you again for joining us, and from us from ASLM, it's always our gratitude to really host you and be able to share with you. Be on the lookout for our next session. Until we next meet, bye-bye for now.